And the reason I think that matters in relation to health is because it's significant when we think about what we're aiming to achieve. So this is a quote from Leslie Doyle, who's done a lot of research in relation to gender equality and gender health. Any attempt to promote gender equity in health must begin with a clear definition of what's being sought. The most obvious goal might seem to be equality in health outcomes between women and men. However, this is clearly unachievable. What this goes back to is the point that we have different biologies. If we know that globally women's life expectancy is longer than men's, and we know that that varies from society to some extent, but in just about every society in the world, women live longer than men, we know that a large part of that is down to biological differences. So how do we know what equality is in terms of changing our policy to try and address men's life expectancy? To what extent are we going to aim for equality of outcomes when we know that biology is playing a part in that? If we could increase men's life expectancy to the same level as women's, would that mean that we had achieved equity? Or would that mean that we had somehow lost some of the advantage that women had? And I don't have any answers. I think this is just a very difficult question. There's quite a good example that's come out of UK data in the last couple of years. The differential between women and men in life expectancy is actually narrowing in the UK at the moment. Now, that's kind of interesting. And in some senses, we might think that's great. You know, this is what we're aiming for, that we're managing to narrow the gender gap. We're narrowing the differences between women and men. The problem is that it comes from two different and contradictory forces. Among men, men's changing health behaviours has decreased some of their risk of heart disease, of lung cancer, and so on. Reductions in smoking and some changes in other health behaviours have meant men's mortality is decreasing to some extent. There's also been a reduction in road accidents and a reduction in suicide mortality, which means that for men, the increase in their life expectancy is a positive. It's actually reflecting an improvement in their health. The changes in women's mortality, however, reflect changes in women's health lifestyles, and in particular, it reflects changes that have been going on for 20 or 30 years or more in the context of women's smoking, combined with women's increased alcohol intake. So the changes for women's mortality are not a plus, they're a minus. We are losing some of the ground that we had. So this really creates quite complicated issues for us in terms of what outcomes we actually want to achieve. And we clearly don't want to achieve an equality in terms of equal life expectancy. That's why it's different to other policy arenas. With education, we can be looking at achieving equal outcomes in terms of GCSEs or A-levels and so on. When it comes to health, we are always going to be wrestling with this complicated problem of the impact of biology. So I just want to spend a little bit of time looking at some of the strategies that we might put in place. And I've sort of grouped these around gender mainstreaming, which is a sort of central part of any approach. Organisational approaches, which is where I'm thinking particularly of what organisations might do within their structures to try and address gender equality and gender equity. A word or two about information needs, because it's always one of the things that we need to consider. And then a little bit of a thought about what barriers might be in our way to try and achieve some of these things. So gender mainstreaming. United Nations in 1997 defined gender mainstreaming for us, and this is the definition. This has become the classic definition, if you like. Mainstreaming a gender perspective is the process of assessing the implications for women and men of any planned action, including legislation, policies, or programs in all areas and at all levels. It's an across-the-board and drilled-down approach to gender equality. It's looking at the ways in which in everything we do, we might consider gender and the impact of gender. It's seen, therefore, as central. Gender mainstreaming is the central plank, if you like, off which many of our actual individual and tailored solutions are going to hang. It's where we start in terms of making sure that gender is integrated at every level. So what does that mean in terms of health policy? It firstly means that we need to identify the gender differences. We need to know, and we need to have a very good grasp of differences in health experience, differences in health needs, and differences in terms of the resources we have at our disposal to implement improvements to our health. We need to consider the differences in terms of use of services, and this is so significant, and people have already referred to the fact that we know that there are huge gender differences in how women and men make use of services, the extent to which we recognise symptoms, we use healthcare, and also the ways in which we're treated within healthcare. It means that we also need to think about gender at every stage of policy development. So we start with policies, and we consider what's the gender impact of those and the ways in which we might bring gender into. So the example of the baby pack is a fantastic example of, if we gender mainstream, we're also looking in what might seem to be quite diverse activities. What's the gender impact in this? What are the opportunities to make a gender impact in this? In what ways can we use this as an opportunity to develop our strategy? So we're not simply thinking of maybe some of the more obvious ones, but thinking sort of across a different range of policy strategies. We have to consider gender in terms of implementation. At what point do we consider gender? Well, it has to be right at the very beginning. We have to start with what are the likely outcomes, what's going to happen, what's the gender impact of the strategy we're developing. We then need to follow that through with monitoring and evaluation, and quite honestly, this is often one of the areas we're not very good at. So we might start with sort of quite sensible and good strategies, but we also need to develop systems, particularly health information systems, that allow us to monitor what we're doing and evaluate what we're doing. And often that means talking to people themselves. We need good, robust outcome and satisfaction measures that help us to know what's happening to people. And we also need training and education. This is the kind of classic and standard core. We need a range of different ways in which we share ideas, we learn from good practice, and we make sure that we're taking people with us. To use an example of what I would describe as an organisational response, gender budgeting and gender budgets. I think in Scotland you're a lot better at this than we are in England. I think this is one area where, well, more than one area where we can learn from Scotland, but this is a good example. Often described as gender responsive budgeting, which I think in a way is quite a good way of trying to sort of encapsulate what it's all about. It's about looking at gender in terms of the ways in which we set budgets. There's a quote there from the European Council. It's a gender-based assessment of budgets, incorporating a gender perspective at all levels in order to promote gender equality. So again, the objective of these strategies needs to be quite clearly understood from the beginning. But there's also an argument that some people would put forward that it's just good budgeting. And I think that relates to some of the ways in which gender equality strategies can be promoted and some of the ways in which we might challenge the kind of resistance, is that actually if we use our money more efficiently and more effectively by targeting and by taking gender into account from the beginning, we're more likely to achieve an improvement in health, which is, after all, the goal at the end of the day. So what gender budgeting really means is trying to assess funding decisions to evaluate the gender differences in what we do. So to try an example of that, we make budgetary decisions all the time on these kinds of things, on services. There's an opportunity cost in one set of services compared with another. We talk all the time, we're making decisions in relation to budget about location. Where do we put services? Do we put them nearer to workplaces? Do we put them nearer to people's homes? We make similar decisions about staffing, what level of staffing, what sex ratio of staffing. The ways in which we staff a service have an impact on gender uptake and on the ways in which people use the services we provide. Thinking about clinic times, this is a very classic one, I think, and it's one we're getting much better at. The ways in which we open our services have an impact on who is most able to use them. So different times of the day are quite important for different groups of people. And also referral policies. How do people get there? Is it self-referral or is it referred through a medical system? In which case, we're maybe creating barriers towards one or other, either men or women using it. And in order to consider those budgetary decisions, what we do in gender budgeting is then look at the differences between women and men in all of these other factors, previous service use. So we want to know what services are men and women using before we put a new service in, and which aspects of that are working and which aren't. So making a decision to spend X on a new clinic, say, in a particular location, we need to know what's already happening and whose needs are not being met by what we've already got. We need to think about new users. We need very much to think about user satisfaction. We might find people are taking our services up, but we don't know very much always about how well they meet their needs. How difficult was it to get there? What other complicated arrangements did they have to make in order to use that service?